Conservation and Public Health at the University of British Columbia. Dr. Frank specializes in the interaction between land use, travel behavior, air quality, and health, and the energy use and climate change impacts of urban form policies. He coined the term walkability in the early 90s, and his work led to WalkScore, and has been cited over 28,000 times, making him one of the 2 most cited planning academics in the world. Thomson and Reuters has listed him in the top 1% globally since 2014 as a highly cited researcher. Dr. Frank has published over 160 peer-reviewed articles and co-authored 2 of the leading books, Health and Community Design and Urban Sprawl and Public Health, which has helped him to map out the field emerging at the nexus between built, natural, and social environments and health. Larry is a pracademic and believes strongly in the development of multi-sectoral partnerships with practitioners and decision-makers in government, the private sector, and NGOs who are able to implement evidence-based results.
So does this? Yes, it does. So it does. It works. Thank you. That was a little, I appreciate the introduction. You did that so well. I need to fix the number because we care about numbers, and I guess, okay. Doesn't matter. So, planning and health are quite different fields with different histories, although in fact they share common roots. Urban planning grew out of public health concerns in the late 1800s, mid to late 1800s in major cities. The cities during the Industrial Revolution got to be really, really polluted. I think we're all really aware of that. But the health problems were things not only like exposure to air pollution, which was so bad from factories, but was also miasma, spread of disease. So the result, planning result, was it gave rise to the need for planning. In fact, how many have heard of a legal tool called zoning? Everybody know what zoning is? Zoning is legally designating how a piece of land can be used. It's predicated on the legal requirement of health, safety, and welfare. We zone land and regulate its use in a way that's arguably, since 1926, when zoning was actually legislated and put into law in both Canada and the U.S., was in the mid-20s. It was in the U.S., the precedent court case is Euclid versus Ambler Realty in Ohio. And it was used as a way to zone out high-density housing in a fairly affluent neighborhood. It's not supposed to be used that way by legislative law. It's actually, that's exclusionary zoning and has a social justice and equity implication. It wasn't supposed to be used that way, but it always has been. So zoning was, who knows why zoning, what was the health basis for zoning? Why did we need zoning from a health perspective? Anybody know? To separate where factories were from where people live. So that's good. That makes total sense. So that's, in a way, got to be coined the term Euclidean zoning a little bit. So you separate where the factories are, but what we did was we kind of got a little overwhelmed, took that a bit far. So we ended up with the houses here and the shops and services over at a different location, and separating everything out to the point where we mandated and regulated and made it essential to be able to get between places, often using a motor vehicle, a car. We created a car-dependent environment, and the result was sprawl. So sprawl was a legislated, regulated tool, a response to health issues in cities. So that in fact, we ended up with a landscape that was very car-dependent. And then we ended up with chronic diseases resulting. So now we have another health problem that ironically is sitting on top of a regulated landscape that is a function of a legal tool that is predicated on health itself. So what we're going to be looking at over the next 10 to 20 years, as many of us working here in SPPH and elsewhere build up with others around the world, we're amassing a lot of evidence. I'm going to present just one study. It's got a lot of data in it, but around the world people are focusing on this. We're going to need to revisit how zoning gets used. That's going to be necessary. We're going to need inclusionary zoning. We're going to need to regulate and mandate mixing of uses because separating uses results in sedentary lifestyles, air pollution from driving, and more health GHG emissions, not to mention massive greenhouse gas problems. I just came back from a summit of mayors globally, the C40 summit in Copenhagen, where they're now rewarding and looking at ways Bloomberg and others globally are working very, very effectively. In fact, a lot of the mayors of the biggest cities of the world are working very hard together in rewarding and identifying best practices to reduce GHG emissions any way possible. So really creative stuff. And transportation is seen as the area where some of the biggest gains can be made. So I need to figure out how do I advance this. Is there just the floor? Okay, cool. Thank you, Hin. So I want to acknowledge and thank Hin and George for their efforts for this series. I know it's always a challenge to make sure that you get everybody lined up and speakers, so thank you and for the opportunity. So this is a simple way. A lot of the work I do, I use the term pracademic. I deal a lot with practitioners, end users. So the city mayors, regional planning agencies, TransLink, I work all the time. In fact, they're not research funding agencies, but they will fund us to do studies. We call them studies, projects. They're not in the business of research for publication and putting a report in a journal, an article, or on a shelf. They need tools. They need ways to deal with the public and the public's misperception and often misperception that, for example, widening roads is going to solve our transportation problems. In fact, often argue that if you widen the highway, people won't be stuck in traffic and we'll have less air pollution. And that's a primary result, but the secondary effect is when you widen the road, you make it easier to drive, people live further out, and you get more and more sprawl. You cannot build your way out of congestion. It is not possible. It's never been done successfully. The widest roads we have on the planet are the most congested. I just saw the head of the Los Angeles Regional Planning Agency, who's now moved to San Diego, speak in San Diego over the weekend. It was fascinating. He had a mayor from a small city called Coronado. How many know San Diego? Coronado Island sits at sea level. The mayor of Coronado was up there on the stage saying, the only way we're going to get people from A to B is by car. And you fools who are thinking that transit can work, we can't afford that. Transit's so expensive. It would be 24, all kinds of statistics that externalize all the health impacts and the environmental impacts of transit, and actually don't really look at a quality transportation system where transit is competitive like we actually have and we're building here. So the mayor was saying from Coronado is that that's the only way to get around, and all I could think of is, how ironic. What city is going to be underwater first in the United States? One of them is Miami. The other one may very well be Coronado. So this head of the regional planning agency was sitting next to him, and he said, you want full cost accounting? We'll give you full cost accounting. You're not going to like it. Because when you start to look at the health, and that's what I'm going to talk about now, when you start to monetize the health impacts of a car-dependent culture and lifestyle, and you start to look at the chronic disease that come from sedentary living and from lack of physical activity, the dollars add up really, really quickly, in the billions. We showed, and I'll get to this at the end of my talk a little bit, $100 billion will be saved in Los Angeles by implementing their active transportation program. They have, all along the West Coast in all cities, we have about $11 billion set aside for transit right now, for infrastructure, for capital expansion. That includes money for the Broadway corridor. We need more. Seattle has about $50 billion. Portland's got about $22 billion set aside right now, roughly speaking. I don't know the exact numbers in San Francisco. Los Angeles has bonded and put aside $165 billion. They're building rail across that entire region very, extensively, very expensive to do. So transportation investments, what we build, results in behavioral changes in the form of developers deciding what they're going to build and where. So there's where and how. So the biggest thing we have to control growth is where we build infrastructure. We make places available and accessible. So in real estate, there's what are the three most important factors that affect land value, or where people choose to live? Location. Location. It's all about location. And what makes a good location? Regional accessible is where we build. So the regional decision making decides where infrastructure goes, where the roads go, where transit lines go. That lays down the bones of where growth can happen. When you build this, you're going to get that. Developers aren't going to build high density to freeway interchange as much as they're going to need to build at a transit station, the density, because accessibility is so highly concentrated in one spot. That's what, and so the distance decay in terms of accessibility, every foot you walk away from the train station, the land value declines more quickly because access is so precious in that land, so valuable around stations. That gives us a consolidated growth pattern versus automobile accessibility, which is ubiquitous. It's like a blanket. It's even. And so that's what, and then we believe and measure, and now we causally have assessed. So planning and transportation planning did not have much of a tradition at all of longitudinal data collection. There were no RCTs in transportation before randomized. There are now because of health. So health is brought into planning, way elevated the rigor of data collection and analysis and evaluation. That's just really making that discipline much different. Transportation is extremely data dependent and has always been. Travel demand models are fundamentally numerical expressions of how people get around. They measure every link in the transportation system from every origin to every destination. That's called an origin and destination matrix. And every zonal pair, where we are and where you are and where you want to go, that's an O and a D. And depending on time of day, we get different travel times because of congestion and the direction of flow by mode. That's been known, but the data behind it has always been, very thinly sampled, for example, very few people, never longitudinal. That's changing. The discipline is really, really changing. There's a ton of data on behavior in those travel surveys. TransLink has 30,000 people in its new travel survey, and it's really quite a good data set, and it's very spatial. We have origins and destinations. We know where people go. Every time we use our card, what's the blue card? Compass card. I have one. Every time we use that, people now, we're getting obviously massive data explosion in transportation, fascinating time. So we really know when we build stuff, we kind of know what will happen with developers. We can regulate it and control it a little bit, at least now, not always. Behavior, health, and dollars. So the idea is that we need tools from our research to be built so decision makers can use that they capture the cost benefit of health on the front end, not the back end, so that we know that when the choice is made to build that or that, and this comes with active transportation infrastructure to support it, that the full cost is there, that you know what the cost might be in the future when you take it all into account. So there's 3 levels, policy levels, that we kind of intervene at when we build cities. The regional level, which is transit access, highway building. I just talked a lot about that. So that's more the where you're located in the region. So you can have a walkable node at the edge of the region. Could be, what's an example of a place that's maybe downtown Langley, the old Langley City. This is pretty good, got older bones, was built a while ago, but it's very far out. So even though it's walkable, it's where, it's how is good, how it's built, but where regionally, that requires a lot of distance of travel, and without the transit line that's going to come there until it does, people are probably generating a lot of GHG emissions who live in Langley City, even though when they get home, they might walk around and have dinner nearby, maybe they can work nearby, but that transit connection is going to be needed for that to change. Walkable neighborhood, so this is the middle level, so this is the local kind of neighborhood scale. This is where we've been at this scale, which is mixed use density, street connectivity, the things, destinations nearby, and having compactness. But it's not capturing yet the micro-scale pedestrian environment. Now these features, if you have good regional accessibility, you've got transit services good, and you have a lot of destinations, you could still not be capturing a lot of potential where the cost benefit from an investment might be quite high, that in fact people would walk, but the pedestrian environment is not very good. And that's cheap stuff, really. Seating, lighting, benches, street furniture, eyes on the street, prettier urban design. So that's where we have a huge opportunity to make advances and starting to monetize things like for elderly, having seating or good crosswalks. These are intuitive things that we even understand as we just walk down the road and see ourselves. But to be able to measure it and show decision makers just what the real benefit really is can be quite helpful. And this is where there's now new tools using Google Street View, automating systems, using machine learning. We're just gobbling up data and building measures, so we're teaching computers to be able to recognize that's a bench, that's a sidewalk, that's a tree, and then you can just use Google Street View and go up and down every street around the whole planet. So that's happening. Oops, I keep making a mistake. So we understand the health context with obesity, high blood pressure, diabetes obviously linked, but the numbers are quite alarming, and we're actually probably in some of the better situation in North America. It's far worse elsewhere. But you can just see 20 to 25% of the population obese, high blood pressure under 20% but pushing up, and diabetes, under 10%. However, the numbers get much worse when you look within certain subpopulations. In fact, I have looked at some statistics showing African American population in the U.S. that there will be very few, and by 2050 or 2040, that are not obese, and and diabetes is horrendous. The rates are horrible. So this is just becoming a crisis. So we have in Canada more recently a lot of talk about the built environment, how much action is really happening or change. Have we really shifted our transportation budgets from roadway nationally, if you look at the numbers, significantly into transit and active transportation? A little bit, not a whole lot in most regions, big regions. We have here done a better job, but the mode split, the percentage of trips by travel mode follow roughly the percentage of dollars spent by travel mode. Isn't that a shocking thing, right? So we get what we spend and we make it the relative utility. Transportation choice, the choice to drive, walk, take transit, use a scooter, whatever, that's a discrete choice phenomenon. That variable, that's a nominal variable mode choice. It's a complex one, but it's all based on relative utility. So what that means is when we model it statistically, we use, how many have heard of multinomial logit, discrete choice models? Used them ever? Anybody ever run a multinomial logit? What did you run it? What did you use it for?
We used it on the CCHS, the claims data.
So, but it was choice. It's a consumer choice. So Daniel McFadden won the Nobel Prize for it. I think it was at Berkeley. And basically, it's the ability to, people that care about it are selling stuff, like car sales, or they're selling toothpaste or whatever. They want to know. You can do, for example, we want to say, what's the likelihood someone's going to walk? You could be investing in pedestrian infrastructure and lose mode share because they just opened a brand new road, or they made because the competing option became better somehow. So you have to look at not just the side of the question you're interested in. You're not going to solve it. Just you can be at the same time building transit and active transportation, but they're spending so much money making driving easier. You're going to get, it's like you're just running right at the wind. So that's what we need to understand. So we have leadership that are starting to get a handle on some of this, but what we need is institutional, interagency collaboration horizontally across sectors, fusing together decision-making on transportation and land use and health, so that the understanding is that, and that needs to come from above. It'll never come from within any line agency that's in a discipline. It needs to come from above the disciplines to say, hey, in my city, I want to have the health department work with the transportation department and the land use people because it costs us all together hugely if we don't. But that's the kind of thinking that this research we hope will inform. But that's not really happening quite as much yet, but this project, Where Matters, is helping to do that. That's exactly what the conversations are. The Health Authority did it together. I skipped at the very beginning the introduction of who's doing the project. I kind of went right into it, but the funders of the project are TransLink and Metro, and the City of Vancouver, the Health Authority, and the Real Estate Foundation, and us. So that's a nice collection of a group to have the Health Authority and staff working directly with the transportation, and now they're developing their own relationships, and they're doing their own projects together, and we're starting to see more and more collaboration. So the policy background for our region is Metro 2040, the regional transport, these are getting updated now. I think it's going to be 2050, so these are all getting updated, and health is a prominent because the public relate with health. So in fact, the city of Vancouver and City of North Vancouver, Mayor Buchanan Linda Buchanan this is all she cares about. She's a health practitioner who's now mayor. This is her entire focus. So we're seeing people like that, and they're not just looking at health as sort of like we need to deal with health. That is the organizing principle and lens through which they're doing all their planning, because they realize the public relate to it. So everything should be about wellness of the public as a fundamental principle. It makes sense. It probably always should have been. We certainly agree in school population and public health that's the case. They weren't thinking that 10 years ago. And 5 years ago, they put the language in their plans, but they weren't really investing in it. Now, you're going to see that really become... So this is at a real deflection point where we're starting to see this really take form, and how to measure what gets done and the effectiveness of the outcomes is going to be really important. So that's what this project is about. We actually have an agreement now with Metro, and they're going to be releasing some new findings. Their regional growth strategy is the policy document and plan that guides and shapes the future of our region and how it's going to grow. That's what they use, and then they have all the cities, so that's the region, and then each municipality is supposed to do its part to adhere to the plan, to invest and make land use decisions so that it's consistent with the regional transportation and land use framework. We're going to be using our walkability, they're using our walkability data sets. We built one for 06, 11, and 16, and we're going to start to be measuring changes in the built environment between these different waves, and they're going to use that information to inform and measure the implementation of the regional growth strategy going forward. That's a huge win for us here at UBC and SPPH, because we're actually producing the data set that's being used to monitor the implementation of the regional growth strategy in part. There's other things that are involved as well, but that's really exciting. So we hope to see how that could be done, and then for example, if Surrey becomes a lot more walkable, performance-based transportation funding can start to be used to say, look at what Surrey's doing. They deserve more money for transit because they're making an urban form and a built environment that will support transit. Why not invest in transit where people will continue to use it more? Now, as you know, we're not in a situation where we have a hard time getting people on transit in this region, apparently. We're actually having a hard time getting enough money for transit to support all the demand for it. But it's still the right metric to say to, the rewards need to follow. You need to have the rewards in place to get the behavior that you want to see. So the study goals, we wanted to investigate the relationship between the built-in natural environment and health. And then we want to look how it varies across age and income. We had enough data to do it. We're using surveillance data set, MHMC, My Health, My Community, Catherine, My Health, My Community, and we also had Trevor's here, the BC Generations data set that Trevor's in charge of. The Generations is a national cohort, and I guess is there a new wave of Generations coming along soon?
There's a follow-up survey that will be available in the next 6 months.
Wow, so the second wave is going to be available
There's a
soon.
follow-up on sort of health status and chronic disease and some lifestyle data.
Cool. So My Health, My Community is going to be longitudinal as well, and that's like 30,000. We had a lot of bigger sample, but Generations is more detailed and is a more representative. It's sampling, but My Health, My Community has a tremendous amount of wonderful information in it, and we need to weight the data to make it generalizable, which we did. So that is something that we felt wasn't obviously we had to do, but that worked. But we have so we're triangulating. We have two different outcome data sets tied to the built environment. So I'll talk about that. And then we wanted to investigate the extent to which the cost piece. So this is kind of the real guts of the project. These are the factors that we can affect through policy. These are our levers. The transportation infrastructure, the land use, the walkability, pedestrian environment, and those are the three levels that I talked, and then green space. And these influence travel and activity patterns, where people go, how much time they spend there, what they do, and how they got there. That then in turn affects behaviors and exposures. So, we have, or as part of behavioral and exposure, but these interact. So you've got to think about it's not just where we go and how we get there and how active we are in that process. It's what the air we breathe and the noise we hear and all those other things, and the safety from injury and crime and all those factors. So there's behaviors and exposures that affect, and I think this is the real interesting thing with There's now more and more data on biomarkers that's available, that we have spatial information where people live, so we'll be able to separate out people that have, like, are predisposed to having diabetes versus those that aren't. So the biological response, and there's a whole emerging epigenetics discussion going on where we start to wonder the biological response to place over time, the methylation and gene expression, and we have a huge amount of expertise on that here at UBC, maybe one of the best places in the world for that. So these are the questions, which is what is it about our body and how it reacts to all this stuff, and then how does that affect these physical and mental health outcomes, and then what does it cost us? So that's kind of the more complex model, but shown graphically. So that's really kind of what we're trying to measure as much as possible, simulating this relational, these relationships. It's a path model. It's a what do you call that? Structural equation. We're modeling using structural equation techniques, and so these are mediation analyses, I guess. So in the simple way to think about it, we need to measure the built environment. We're trying to predict behaviors and then the health outcomes. And then for now, although we have in Trevor's data in the PC generations, and will in the future with My Health, My Community, the electronic medical record match. So in generations, we actually are using the POP data. That was a big part of the project, was to actually just literally link people's healthcare record with where they live. And Hind spent a lot of time with us trying to did successfully, with great effort, getting access to be able to do that. And so now we have all that put together, and we learned some interesting things through that, but we ended up for the project using, for now, when we rolled this out for the public, we used a cost of illness methodology, but we are able to show the relationships as well and have them for actually how much expenditure really happens. Lots of complications. I don't know how many have used POP data in their research. And you all know the complexity of it. So it's not the full expenditure history because it's the medical records. It doesn't capture extended health care that we get from when we work for places. So it only has part of our medical record, and there's some other, it's really hard data to use. So we're still learning how to use it. And I think that we can get help probably from people here that know how to use it better. So anyways, that's our project structure. So we have, the first phase was a grant I got from CIHR, fairly modest sized small grant. That was to work with the BC Generations data set. And then we got this My Health, My Community funding. And now we're going after a third phase, and we have some initial positive feedback that looks like it's moving forward, and hopefully we'll get funded. And we're going to be dealing with a whole bunch of future questions, focusing on the cost side a little bit in greater detail, equity and housing issues, and then possibly the pedestrian environment. But there's lots of ways we can take this project depending on our client base and who we have. We're actually interested in the interface more so for the second phase of GHG emissions, the greenhouse gas, and health. So we may actually wait for now to do the longitudinal analysis. I'll get into some details about that and just show you what we've done so far. Something happened here that doesn't normally look that way. Anyways, I already kind of said the structure of the design. We got basically these two data sets linked to the built environment. So once you build a surface across a region and you've measured every postal code like we have, our walkability data uses parcel data. So we're right down to the parcel, and we measure the whole surface of the region, and we have it's like a blanket, and so we can land any survey address on it, and then you have questions about how much time do people spend there, exposure, their behavior from their record, and you can correlate their behavior and who they are demographically with where they live. That's the kind of the link, and that's what we did with two different independent data sets. This is the comparability over time of each time we do a new wave of walkability, we add new things to it. So now they have sidewalks for the whole region. So we actually know where the pedestrian infrastructure exists and where it doesn't. So that's very helpful. So this is a tool to support research for anyone who wants to use it in SPPH. Basically you can work with us It's available, so if spatial measures of the built environment and natural environment are useful in your research, that's what the Health and Community Design Lab is here to support. So we're trying to, figure out ways to collaborate with more. We have capacity limits, but we also have ability to expand in certain ways under certain conditions. We can add more. And so now we did for 2016, we built our, let me see, I got to move to the next slide to explain this. Perfect. So this is, we use a network buffer. We've published extensively on buffering techniques and spatial measures. This is what we kind of core expertise, is how to measure places. So there's been a whole big evolution over time. The state of the practice is what's called a sausage buffer. This is a household. When we simulate as best we can someone's experience when they walk out the door of their house, or where they work, or where they shop, or anywhere, we can measure, we grow a buffer on the road network and attach the parcels to it within a certain distance. We've done it at the kilometer, 800 meter, and 400 meter. Regional planning agencies are using this 800 meter as a measurable distance around transit. That's a policy guidance that they have that they need that for. But when we want to look at elderly, we might want to look at the smaller distance because people who are older may not be able to walk as far. So this is likely to correlate better with their behavior. Where this is going is going to be something very different, because what if just outside the buffer is a major destination and you miss it? We have an edge condition superimposed when in reality that's not, you don't walk to the edge of the street and go, oh, this is outside my 1 kilometer buffer, I'm not going any further. Like you can't get your feet glued to the ground. You can't, it's not what happens in real life. So there's something called kernel density, and it's sort of so it's developing sort of a distance decay function that simulates the likelihood you will travel to a place based on proximity, which is nonlinear. So we exponentially drop our interest in what's 4 blocks away. We are like 20 times less or 5 times less likely to walk than what's a block away. It's not a linear. Distance decay is more kind of like, or you can think with proximity, you're much more exponentially more likely to go to a place. So that's how it's going to be done, and it is being done by some that way already. So this is when we can, we map it. This is actually a poor map, to be quite honest. It's kind of coarse. It shows what we get when you put it all together. And this is a simple way to communicate, we quintiled it. So we basically took walkability as a continuum and we cut it into fifths so that we could run our logistical regression models and show the likelihoods shifting. When you run a logistical regression, you need to have a significant difference between steps as you go up a staircase. So our reference group is typically car dependent. And just getting the agreement from the agencies of what the labels could be took us like months. Because everybody has that has a policy meaning for Metro that you can't use that term because some of these places don't correlate with what we call. So we finally got to this decision that this would work. And I had to push really hard for the term car dependent because it has a negative derogatory connotation. But I wasn't going to give up. I'm like, you know what? That's car dependent. Like, I'm sorry, that's what it is, They were like, how about less walkable? I'm like, no, it's that's too wimpy. It's car dependent. And they were eventually okay with it. So and then you take a place, this is older. Actually, Andrew Devlin was a student of mine who's now, was at TransLink, and now is the planning transportation lead at the city of North Vancouver. So he is my student. He did this years ago. He built the first walkability data set. So if you're staying in a place long enough, you have your students, right, as we all know, our old faculty who are my age, and similarly, you get to know people in agencies because they were your students. So anyways, this is our composite. We've been doing this for 20 years. But anyways, density, mixing of uses, the connectivity of the road network, cul-de-sacs versus a grid that is connected, and then this other measure, which is retail floor space ratio we call in Canada. These are all regulated things. These are things that codes and zoning and development regulations for cities, subdivision, zoning, and building codes control. That's good because it means they can do something about it. You can talk to a city planner or a mayor, even an elected official, and they go, oh, these are things I know how to deal with that. I can need to change my zoning code, my subdivision code, so that we get more intersections per unit of area. Intersection density, we can control that. So anyways, this is a cul-de-sac versus the grid, but the retail floor area ratio is how much square footage you can put on a piece of land. So if you have a 33-foot lot in Vancouver, it's about 128 feet deep, you can put about 3,000 square feet on that piece of land. Most people who own a parcel of land know that. Floor space ratio is a very good measure and proxy for a pedestrian environment. Think of a shopping mall. Huge sea of parking, and then the buildings behind it. That's very low FSR. That's not going to be walkable. So you could even have some density in the spot where there's a building. It could be quite a lot of development. But if you have a lot of surface parking, or if you're not built up to the curb, think of 4th Avenue, Broadway, are walkable streets. The buildings are right up to the curb, and the floor space ratio, there's a lot of square footage per land area. Everybody, so that's and it's proxying for the pedestrian environment stuff, data that we didn't already have. So this is what we showed, and this is very visual, is these 5 ranges of walkability. This is very simple. And then, you can kind of put, this is an ex-urban, suburban, semi-urban, town center, and urban core. And this is an aerial, and then an image. So this is just showing, it's a tool, so people all over the region can look at their neighborhood, and they can see, well, what is it? How does it look? Where am I in this hierarchy? So people can figure that out. So this is the kind of examples of these places. They're called place types in scenario planning. The state of the practice in transportation and urban planning now, a lot of it, and I talk about this in my class, is scenario planning, which is basically a way to measure, because we have such good computing power now, tools are now available to do what-ifs. You can say, well, what if, here's your neighborhood, and what if we built it 6 different ways? They're already doing that. And we brought health into that discussion. That's been our goal. So the idea is to make practical tools that can be used. So this is these different individual, we call them plates. These are the individual measures, and they're all quite different. In fact, their spatial variation can be quite unique. This is the FAR measure. The commercial is quite different than the density, and so each one's different, but they're highly correlated, even though they show some difference with each other. They're so highly correlated with each other, we have a problem with multiclinearity. Can't really tell. When you put them all into a model separately, the model blows up. So we create a walkability index. You could do that a number of ways. We take Z-scores and we sum them, and that means that we're not weighting one more than the other. But we could do principal components, many people do, so that you pick a vector, you have a vector created of a commonality, all kinds of ways. Sometimes they're not so correlated that you can't have them in separately. Policymakers want to know the individual effects, typically. They go, is it mixed use that's going to help here? Do I need destinations, or is it more density? They want that like you're writing a prescription for a neighborhood, and what's the perfect thing to do? Of course, it's a lot of subjectivity to that. This is detecting changes, so we're starting to do that now, the change detection over time. That's really going to be fun. Never done that before, had the data to do that. I hope that becomes a guidance, as I mentioned, for decision making in the future. Parks are really important. We have a very simple measure for parks. It was number of parks within their buffer, within the 1 kilometer buffer. That's our measure. We tried acres in parks. We tried a bunch of different types of measures, but the one that worked the best was numbers of parks, so we went with it. Simple's okay. Simple's not bad when you're trying to talk to people that are not scientists about how to change their community. So this is more parks and less parks, highly correlated with the walkability measure, very problematic analytically, still results in good, and it also, park access picks up wealth. So you can control for income, and I'm sure that in your research, and everybody's aware of this, we say, well, we controlled for income. No, you didn't. You controlled for a little bit of the variation in income. We have an ordinal measure of income in our statistical data, in our census data, but think about the variation that exists even with our ordinal measure of income ranges, brackets, and then above the top there's huge variation, and you're not even touching the concept of wealth, which is shaping behavior. Someone could actually be earning very little and have a tremendous amount of money, which shapes their behavior and their health. So that's the problem, is that they're living near the parks. That's what parks. There's even hedonic pricing tools, if anybody heard of that, which is a distance decay model basically that's used when a park is put into a neighborhood. It elevates the land value hugely. When a station goes in, displacement occurs for the most poorest, for the people that are least able to pay to live there. because of this issue about proximity and land value I talked about a couple times. So this is our regional accessibility measure, and it shows how many destinations in our region people can get to within 45 minutes of the rush hour. So basically, these folks can get to 16 or more centers, and then you can just see the mid-range. It's just a tertile measure, very simple, just to show spatially, as you move from the center to the edge, your accessibility goes down. It's very intuitive, but we can measure it, and we can measure it continuously, or we can make it clunky and make it tertile so we can map it. We could quintile that, or we can do octile, we can do anything we want with it. So these results are very simple. This is the statistical modeling behind it is not. Okay, so these are logistical models. We have path models that Benet, my PhD student, ran, did a fantastic job, where we ran and did structural equation models to look at the path analysis. These are logistical regression results with the quintiles of the measures that I'll show you with the outcomes, and they all have control variables, lots of control variables, demographics and so forth. So what we found is people living in the so there's first point is that you don't have to be living downtown Vancouver, the super highest density, to result in some benefit for physical activity and health. That's the biggest takeaway, is that the biggest issue is the public will hear and think, I don't want to live downtown in a skyscraper. I want to live in a neighborhood where I want a house, or I want a townhouse, or even I'm happy with an apartment in a small building, but I want something green nearby. I'd say a lot of people feel that way. So that our results show, you know what? There is a 20% benefit, for a modest level of density, you can still see a significant increase in physical activity. People in somewhat walkable areas are 20% more likely to walk 30 minutes or more each day, and 45% more likely compared to those living in a car-dependent area for transportation in a walkable area. So we see in this area we're 45%. So that's the range. You get obviously increasing level. Self-reported physical activity data, not the best. Usually we use accelerometry, but we don't have 30,000 people wearing accelerometers, right? So that's the issue. Is that we do these historically. When we do primary data collection, we're equipping people with accelerometers. We did tons of studies like this, accelerometers and GPS devices, and you know a lot about a few people or 1,000 people, and you learn a great deal. But you can't do a model. You can't build statistical relationships on chronic outcomes. You would never have a signal in that small of a data set. So moving down the causal pathway, we now look at moderate vigorous physical activity. We see actually a slight decline in this measure. Now that's not actually as surprising, as that people self-select who like being physically active live at the edge. So some of the car-dependent, we've seen this before in this region, which messes us up, because we're like, well, they're like, what's going on? So we've had this result before, so I'm not so surprised about it. But we still have the result at the top end, which is an increase. And then we get to body weight. Nothing statistically significant. I think the gray means it was significant at the 90% level, and then 95% level or greater is solid. So 42% reduction in the likelihood of obesity from the most to the least walkable. And then we get to diabetes. Now this was relatively new. And here we see a reduction in diabetes risk at 27% and 39% increasing as you move up the walkability continuum. So it's associated with obesity in part and physical activity in part, but it's also probably clearly a function, in this case, self-selection. There's definitely selection bias going on, for sure. And we could control for that, and we did in some of our analysis, because My Health, My Community, this was all My Health, My Community data. So we chose, for our client was in the room, which is the health authorities data set. So in our report, and we're going to be writing up now with Trevor and others, the generations work, which has really good results as well, but not as much sample size, so we didn't have as much power, but we saw very equivalent relationships. So this is heart disease, so only at the highest level. So you might wonder, like, why would, there's other things going on that we did not measure yet. Air pollution exposure will attenuate the results. So if you have in the most walkable areas, you have more traffic, more air pollution. So we might otherwise see, if we were to control for that better, increased effects. So it might not just be a 14% reduction in heart disease. And in fact, for elderly, when we broke the sample apart, I'm not showing today, we actually showed that emerged, was that in fact diabetes and heart disease were lowest in the moderately walkable, and in the most walkable, it actually went back up. Incident rates or risk went back up. And that's a result we expect to see. So that has, for us, some good face validity. So I'm going to make sure I wrap up soon. Stress and sense of community are interesting variables people care a lot about. So here we saw walkability and stress, significant reductions as you move up the scale. In fact, it's probably picking up the lack of the longest commutes that are stressful, perhaps. We don't really even know exactly what's behind that. And then sense of community increasing. Bottom line was that all of our results were in the expected direction, if not textbook. So it's almost concerning, because usually we expect much messier results and we can't explain it. But this time it seemed like it just, maybe the power was so great. And we have such variation in built form in our region. We have very, very walkable places and we have incredible sprawl. So that may be that slope is so steep in urban form that we actually pick up, there's enough variation that we're seeing the relationships that the hypotheses do pan out. So that's, this sense of community is a great measure. It's very simple. Usually we use a composite measure of multiple factors and build a factor score because it's a complex phenomenon to measure someone's sense of community. This is a fairly simple measure, but it certainly came through. I'll just buzz through the parks. So the most parks compared to no parks, 6 or more parks, we see more physical activity. We see, again, measured differently. This one is 30 minutes a day, that recommended amount. And one measure, that was leisure walking. And then this is moderate to vigorous physical activity of all forms of activity was clearly greater. So parks, we would assume, would have an effect on all forms of activity because it picks up recreation. And then obesity declining with more park access. I really think this is picking up an income effect for sure. Because look at the numbers, just goes straight up. Diabetes significantly lower with more parks nearby. Heart disease, all as the number of parks increases. Stress at the highest level, 6 or more parks, and then sense of community being significantly positive related with having more green space. But it's public realm, place for people to get together. So there is a hypothesis that makes some sense that it would explain this. I would be more alarmed if everything was in the opposite direction. So anyways, cost of illness process was applied. I'm sure everybody's familiar with the concept. You're monetizing per unit an onset, and you're dealing with age of a person and their gender, and then you multiply out using adopted numbers. Some societies, some countries have these numbers and some don't. This is not easily replicable in a third world context where cost of illness may have huge variation, but we have numbers for that. We only looked at the directs. We did a very simple first cut through this. We needed to do a lot more. So we're hoping to work with others here at SPPH. Our school has a tremendous amount of expertise in this area, so this is a really good opportunity for collaboration in the next phase. So anyways, we just looked at direct inpatient hospital-related costs. So we calculated direct cost per case by age and gender, and then summarized for each walkability and park quintile. So our numbers showed diabetes care costs are 75% lower for people with 6 or more parks nearby. Hypertension costs down by 47% with those in the most walkable areas. And heart disease costs were down by 69%. We're 69% lower for people with 6 or more parks nearby. Basically, it's a linear extrapolation of the chronic outcomes because, of course, we just applied a unit dollar to it. So it's as expected. If you have less illness, you have less cost. But the indirect, well, first of all, the absolute dollar amounts are not meaningful in this analysis because we really don't know what the absolute dollars really are, and we haven't even scratched the surface on the indirects, which is workforce productivity. And again, we had folks that are really good at measuring that. That, in fact, we saw, because we did run a cost-benefit model on the LA when we monetized the active transportation investment there, and the dollars were greater from the workforce. The loss of productivity was a bigger piece. It was $8.50 per every buck spent payback. So you spend $1 on active transportation, the cost-benefit model showed $8.50 return. It's a good rate of return on investment, of course. And not unheard of. So I think I want to make sure there's at least a little bit of time. So I'm going to stop. That was the LA example I just described. And I think I'll stop there and hope there are any questions. Please let me know. And I look forward to hearing what you think. Thank you.
Thank you very much. That was super interesting and a lot of data and a lot of analysis. So congrats on packaging all of it.
Credit my students and my colleagues.
Absolutely. But it does take some leadership as well. So we have 6 to 8 minutes to have questions. I am gonna scan the room here and then we'll take a few questions from the online audience as well.
Okay, do you want to go first? Okay. Oh, thank you, Larry. It was great to hear about this project. So I appreciated that you were talking a bit about how the built environment and how planning decisions affect greenhouse gas emissions, which a cause of climate change. And I was wondering if you all thought a little bit about the flip side, right, the consequence of climate change, and to what extent the relationships that you're seeing between the built environment and health and costs might be altered in a world that's 2 degrees warmer or 3 degrees warmer.
Great question. Thank you, Kate. So I think what you're saying is as we start to see heat island effect happening in behavior, so how much is likely behavior going to shift? How much more will people really want to walk if it's ridiculously hot out?
Or how does like high density building affect like local temperature, or I don't know, right? So,
yeah, well, those are good questions and things that you're working at, hopefully. I know you're working on. So that, I mean, but it's a regional spatial structure settlement pattern question. I had a student years ago who you may have known, it was in Georgia Tech still. He was there. Anyway, but it was the air moving pulls over the surface of a region in the summer, and then I guess there's what's that called, a convection cycle that's created by heat. Apparently, and the longer the distance from the edge to the middle, the more ability the heat has to accumulate. I guess it's problematic though, because it actually suggests that living at the edge is cooler, and it may drive an interest to be more in an edge condition in a heat island situation. It doesn't work for our walkability model.
thank you.
Larry, I'm so glad I could make it out because I was so disappointed I missed your May 6th workshop to Judge Schedule conflict earlier this few months ago. Anyways, my question is this. So your work on the walkability index is really well known and everything. And this may be a bit of a naive question, not really knowing the results from all the studies. Question is, inherent in the word walkability is about walking. So my question about sectors of the population where they are unable to walk, but disabled, did you take that into consideration in your modeling?
Well, we know that places, thank you, Lydia. And so the question is really about disability. How does measuring a place, the walkability is just a term. It's measuring variation in built form. And the most walkable places are the places where it's even possible for someone who's disabled to get somewhere independently, possibly, and even in a wheelchair. So the pedestrian environment measures pick that up. So and we haven't modeled those in this project yet, but we have in other projects. So curb ramps, curb cuts, smooth surfaces, elderly. I yesterday spoke about healthy aging. So you have even the paving surface matters, seating. These are all factors that make a place possible for someone who is semi-disabled or has reduced mobility options. I think maybe think of it as a continuum, and that certainly in aging in an environment where walking is an option or where they can get somewhere and there's a destination, even a little park. One of those parks could be small, to watch other people, to not be socially isolated and have some sense of community is all really helpful for people who are in a mobility compromised situation.
Hi, Professor. I'm a first-year MSCOEH student. I'd like to thank you for a very inspiring talk. And it was the thing that struck me the most was the numbers of the results. I was wondering if there's a decrease in the cost. What is the cost of building this for the government?
Right. It depends on what you're measuring. Of course, costs are complicated to come to, but we know, well, the Broadway corridor is probably a 3, 4, okay, 5. Probably 5 billion. So the question is, what's the health, does it pay for itself? How do, we know we need to do it to get people around. Region can't function. Everybody can't have 2 tons of metal to get a loaf of bread or to get to work. It doesn't work. There's not enough space. So that it would destroy our reason. Broadway would be 28 lanes wide, and it would be, be absurd. So, and then the greenhouse gas emissions that come from that is not even, so the decision-making process is really, they're being almost pushed into inevitability. But the question is, how do we make the business case for the rail investment based on health, or can you? Yes. And the question is, if $13 billion in pedestrian improvements results in a $100 billion payback in LA, $5 billion going into rail along Broadway versus not is definitely monetizable. But that's a whole process of a series of questions of, do we include pedestrian amenities in that? Is there money to tax abatement and to incentivize, businesses? I don't think we even need to do that in that corridor. Should it be tunneled properly, not cut and cover like Canby was, which destroyed businesses along it? So there's so many factors that go into what the variation in the cost is, and then how we measure the benefits. Both costs and benefits have huge variation methodologically.
Thank you so much. Please join me in warmly thanking Larry for his contribution.
Thank you all for coming.